Doctrine of Munroe Kellie. So when we talk about the Doctrine of Munroe Kellie, without this there is no importance of the chapter. So Doctrine of Munroe Kellie is a very important topic for all of us, and let us try to understand Doctrine of Munroe Kellie. The Doctrine of Munroe Kellie says that skull is a closed vault. Yeah. So it says that skull is a closed vault. What do you mean by skull is a closed vault? Let us try to understand this. So skull is a closed vault, and any addition to this, the USP, the speciality of this chapter lies in this single statement that skull is a closed vault. Unlike other organs, we don't have a freely expanding space or cavity in the skull. So everything relies on this fact that skull is a closed vault. Any addition to it is managed by egress of CSF and venous blood. Now, what is the importance of this egress of CSF and venous blood, and what is this Doctrine of Munroe Kellie? Let us try to understand more. So when we see this, just see, imagine the skull to be like this. This is the skull that we have. So skull is a closed vault, and what are the components of the skull? We have either the CSF, we have the most important component, that is the arterial blood, then we have the brain parenchyma itself, so the brain parenchyma, and then we have the venous blood. So these are the four things that we have, and we don't have an empty space. So now this is the normal skull. And the most important thing about the skull is that any addition to it will be a problem. Why? Because there is no vacant space. So now whenever there is mass, so try to understand what happens in case of a mass. Now imagine this is a mass. There is a mass inside the skull. Now mass is like a guest. You can take this mass to be a tumor. This could be because of a hemorrhage. So how to accommodate this mass is a big challenge. Now what are the components? Try to understand. The skull is not going to expand, and so is the arterial blood. The arterial blood says, I'm not going to compromise for myself. Why? Because if I go down, the complete brain will become ischemic. So we have this arterial blood which is not going to change. Then we have the brain parenchyma, which will say, I am very important for the function of the body, I will not change. Students, if both will not change, then who will accommodate these masses? How you will accommodate this mass? So what happens? You know that some part of CSF is intracranial and some part is distributed in the spine. So brain will ask the CSF to migrate from the intracranial compartment to the intraspinal compartment, and when this happens, some space will be vacated. The similar thing is the venous blood is shifted from the brain into the peripheral, you can say, capacitive vessels. So what is happening here? There is outflow of CSF. Into the intraspinal compartment. So CSF, some part of CSF goes out, some part. Similarly, some part of the venous blood drains out into the what? The systemic part of the body. So do you know that there is reshuffling of CSF and venous blood, and because of this reshuffling of CSF and venous blood, some space is evacuated, and this space is actually utilized to accommodate the mass. And thus this is a phase where you say that this is a compensated state. So compensated state. And this is the reason why in the early stages of hemorrhage or cancer or maybe a tumor, you don't have any presentation there. That's asymptomatic. Why? Because the homeostasis of the homeostasis of the brain, or you can say the skull, is maintained by reshuffling of CSF and the venous blood. Now what is the next thing? The next thing, if this mass expands, So now let us see what to do if the mass expands. So suppose there is expansion of this mass. So the mass has expanded itself. Now how to accommodate this mass? This is very important. The mass is expanding. There is some problem, boss. How to manage this? Already the CSF is actually adjusted to the maximum. Yeah. So there is expansion of mass. So CSF has already adjusted to the maximum it could have. And CSF says, don't look at me. I will not do any further adjustment. Now then the question is, what about the arterial blood? Arterial blood says, I am not going to negotiate for anything. I want my space. And if you want me to negotiate, then be prepared for ischemia. When you look at the venous blood says, don't look at me also, because I have done the maximum adjustment I could have. Now mass is expanding. There is no space left over. And you must have seen the small openings in the skull. And via these openings, what is going to herniate out? So you cannot stop the intracranial pressure from increasing. And thus, this is the concept of what? The brain herniation. And brain herniation means you are going to encounter yourself with what? Neurological deficits and complication. And this is what is known as a decompensated phase. So now you can see how a normal brain changes from its normal state to a decompensated stage. And this is very important. And this is explained by Doctrine of Munroe Kellie. So what is Doctrine of Munroe Kellie? It says that skull is a closed vault. Any addition to it is initially managed by the reshuffling or egress of CSF into the intraspinal and venous blood into the peripheral vessels or systemic circulation. This is very important to compensate the brain, but as the mass expands, it is beyond the capacity and hence decompensated lesion occurs. Now try to understand. This Doctrine of Munroe Kellie has also given us a very beautiful equation. What is that equation? Let us try to understand. Doctrine of Munroe Kellie says that CPP is equal to MAP minus ICP. What do you mean by CPP is equal to MAP minus ICP? Try to understand. This is defined as cerebral perfusion pressure. So cerebral perfusion pressure, and this is equal to the mean arterial pressure. What is MAP? MAP stands for mean arterial pressure. Mean arterial pressure. So we have mean arterial pressure, we have cerebral perfusion pressure, and what is ICP? This is intracranial pressure. Intracranial pressure. Now, why this is very important for you all? Now try to understand. If the intracranial pressure is going to rise, of course there will be decrease in CPP, and this is very important. So try to see, if there is increase in ICP, there is going to be fall in CPP, and if there is fall in CPP, students, what is going to happen? There will be ischemia, and if there is ischemia, there will be neurological deficits. And this is the explanation of every pathology occurring in the brain. So always remember this relation in exam. If systolic BP is given, if diastolic BP is given, if intracranial pressure is given, you can take out the CPP or anything. You have to follow this equation. This is very important. When we are in concern of CPP, let me tell you the normal cerebral perfusion pressure. The normal CPP is equal to 65 to 105 mmHg. You can say even 70 to 105 mmHg. Always remember that less than 60 mmHg, less than 60 mmHg is considered to be a critical value. This is very important. When we talk about the intracranial pressure, the normal intracranial pressure ranges from 4 to 14 mmHg. So when you talk about the intracranial pressure, it ranges from 4 to 14 mmHg. 4 to 14 mmHg. Important is more than 20 mmHg. More than 20 mmHg this is considered to be what? Critical. And this is important, very, very, very important. So more than 20 mmHg is considered to be a critical value. Now we'll discuss about the intracranial hypertension, but when we have started a talk on the concept of cerebral herniation or brain herniation.
Subscribe and press the bell icon so you never miss an update from PrepLadder.